All righty. Good evening and afternoon, everyone who's tuning in with us from across Canada and even internationally. We're so excited to welcome you to another NSWOC and WOCC Institute webinar. Today's webinar is going to be on our Pediatric Incontinence-Associated Dermatitis best practice recommendations, and we're joined by two phenomenal presenters with us today. They're Emily Woodgate and Jonathan Honsberger. And before I introduce them, I'm just going to do a couple of quick housekeeping items. First, if I can get everybody to click on your chat button in your Zoom toolbar, we'll do a quick little icebreaker by asking you to type in where you're tuning in from today. So my name's Troy. I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm tuning in from downtown Ottawa. It's dark outside. It is fully fall, but I think the vibes are still very positive, and we're getting excited for spooky season. So awesome. I've seen people from Calgary, Toronto, Vancouver, Halifax, Sackville, Yarmouth, everywhere. Awesome. Thanks for joining us, everybody. So today we're going to be having Emily present first, and we're going to be talking about, as we mentioned before, the Paediatric Incontinence-Associated Dermatitis best practice recommendations. So Emily Woodgate is our pediatric community of practice leader, and Jonathan Honsberger, is the president-elect for the Canadian Association of Pediatric Nurses. So without further ado, I'm going to pass over the mic to Emily. Oh, I'm sorry, Emily. One more thing. For everybody who's on the line today, we will be doing a question and answer period at the end. So if you do have any questions, please use that Q&A button in your Zoom toolbar, and we'll be happy to get to those at the very end. Okay, now without further ado, take it away, Emily. Thank you so much.
Thank you. I'm looking at all these places. There's lots of Nova Scotia over here. Hello, everybody. I'm in Halifax, so I'm with you on the East Coast. I'm just going to share my screen here. Maybe. There we go. All right. So I am, as Troy said there, the core program lead for the Pediatric Community of Practice. And our first project that we took on was Paediatric Incontinence-Associated Dermatitis best practice recommendations. And I'm very excited to tell you a bit more about these and just let you know that they have been taking off. I actually just did an international presentation about them as well. So we're very excited about these. And I didn't do it alone. I did it with our community of practice. So I just want to make sure that they have some props in this, that they were part of it. All right, there we go. Conflicts of interest. So I have no conflicts of interest. This project was funded by unrestricted educational grants from 3M and Medline, and two of our members are industry partners. What we'll talk about a little bit during this is what is our community of practice? How did we come up with these best practice recommendations? What are they? Very excited to tell you about our quick reference guide. That's one of the most exciting parts of this. I do have a couple little case studies at the end just to throw in there, and then absolutely open to questions at the end. So the community of practice started as a dream. I will give total credit to my colleague Stephanie Furtado, who was the core program lead before me, and she really got this off the ground and running. It's open to all NSWOC members who have an interest in pediatrics. You don't have to be in a pediatric hospital, just have an interest. And the email is there if you're interested in joining and you are an NSWOC. So what is it? What are we doing here? I'm just going to move my little box. Sorry, technical difficulties. There we go. So we wanted to create a national network of NSWOCs so that we could work together, that we could provide counsel and do due diligence for pediatric related initiatives. We wanted to have a way to take all of our problems that aren't necessarily able to be researched due to ethics and identify ways to improve on those and do projects like these best practice recommendations. So we had our first meeting in February of 2021. At this meeting, we just threw out rapid fire all of the ideas you had. So you can see the list here that we came up with, and we voted and decided our first project would be Pediatric Incontinence-Associated Dermatitis. We made a task force, which was 14 members. We had a literature review done with the help of Dr. Kevin Wu, who I'm sure many of you have heard of, pulled all English papers from the last 10 years that had keywords. We had picked out a few keywords we wanted involved in this, and we came up with 174 manuscripts. Each of those was read by 2 people. So it was a lot of work. I'm just going to flip to this next slide. I in no way expect you to be able to see this, but this is everything that we had to pull out of these papers in order to find out what figures we liked, what ideas we liked, what made sense, what was coming up over and over again in the literature. From here, we collaborated all of this research together and were able to come up with recommendations. We took those recommendations then to a Delphi process. So if you've never been involved in that, it's anonymous way to go through and say whether a recommendation is significant, important, how important, if it really needs to be included in the document. That document then went for peer review, and now we're able to present you our 9 best practice recommendations. So I will absolutely tell you that I renamed all of these just to make them a little bit more exciting, because incontinence-associated dermatitis is not necessarily the most exciting topic to talk about, but I'll go through them for you here. So the first one is assess before you dress. So how often have we heard, oops, oh, what did I do? Troy, what did I do?
Did it just skip a slide?
I think I skipped to the end by accident.
That's okay. I would just pull up your PowerPoint. You got it.
Oh, technical difficulties. See, I like to talk about bums, but I can't do PowerPoints. All right, here we are. This one.
Perfect. And just from current slide.
There we go.
Looks great.
All right, I'm gonna press the right button now. So how many times have you seen a patient and heard it's not working, nothing's working, we've tried everything? So you really have to complete a holistic assessment, head to toe, before you're able to say what you're going to dress it with, what kind of cream you're going to use, how you're going to treat. You have to know what the underlying reason is for even diaper dermatitis, whether it is moisture. This is a list of risk factors that is in the document that you'll see that actually put patients more at risk for diaper dermatitis. So if you can eliminate those risks, that's the best. Knowing why will help you choose a treatment path for the patient. The second recommendation, easy as ABCDE. So advocate for a consistent approach for the prevention and treatment. So that addresses the 5 components. And I know these aren't in alphabetical order here, but A is for air, so let it dry, not necessarily a hyperbaric chamber or oxygen, but just letting it dry, making sure that the skin is not completely macerated, those cells aren't swollen, it's not affecting the pH of the skin. The B is for barrier, so using an appropriate barrier. Sometimes we don't use anything when we really should. So what does the bum look like? And I use bum all the time. I am a pediatric nurse, so bear with me. What does it look like, and what kind of barrier do you need on there? Also making sure you know what's in the barriers that you're using. A lot of our common ones on the market have lanolin, which can be a high allergen. There's a list of allergens in this document as well. C is for cleansing, making sure you're using a pH balanced cleanser with emollients in it to break down all of the debris that's on the skin. Diapers, using super absorbent diapers, and changing when they're soiled with stool, not necessarily every time they're soiled with urine, but definitely every time they're soiled with stool. And E is for education, and that's both families and staff, and the child if it's appropriate. The next one, how many times have we walked in and seen this on your bedside table? So 3 is keeping it simple. And I understand the ask that we are asking here, but streamlining the care products that are in your healthcare organization. This was a picture, and when I get to my cases, I'll tell you about the patient, but this was a picture of the creams I found on one patient's bedside table. So myself and my colleague have been working really hard to try to streamline what we have available for our staff to pull off the counters or order, so that there's not so many options, but there is an option for each category that we need there to be an option for. I will not sing to you tonight. I am not a good singer, but don't stop believing. So defining the duration of time. We often hear it's not working, because we've tried a cream for 4 hours and it hasn't improved the skin. You need to let something work for 3 to 5 days. So we kind of set a minimum as long as things aren't getting any worse. So there's no reaction, there's no symptoms that are getting worse or pain's not getting worse. We set a minimum of 3 days before you change what you're doing. Give it a chance to work. Call me maybe. Call an NSWOC or your qualified wound care specialist if what you're doing isn't working. So if you've tried everything on the list, and I will give you the list, our quick reference guide, if you've followed these recommendations, it's still not working, seek some help, because there might be something, there probably is something underlying that you need help with. Hey, do you want to do something about that yeast infection? If there's a yeast infection, you need to treat the yeast infection. So adding in an antifungal, whether that be a powder, a topical, an oral, that yeast needs to be treated and treated until the symptoms have disappeared for at least a few days before you stop it. Communicate clearly. This clip never works for me. I won't even try it today, but if you've ever seen The Notebook, oh, is it gonna work for me? Oh, it's gonna work tonight. There you go. Oh, sorry, I didn't mean to play it again. So make sure you're communicating clearly. If you're just reaming off big words that the family doesn't understand or not documenting, nobody's going to know what to do with this patient. So make sure that you're standardizing the documentation, you're communicating with all the healthcare professionals, making sure the family knows what's happening, as well as the bedside nurse, the child, if they're appropriate age and cognitively aware. Make sure that you're communicating what you want so that there's no confusion over what's going on. Oh. Yeah, there we go. And stop, collaborate, and listen. So educate and collaborate with everyone involved. Again, make sure that the bedside nurse, the family, the OT, the physio are all involved in why we're doing what we're doing, so that it's not just a treatment, but also prevention and management going forward of this dermatitis. And then number 9 is refer to the quick reference guide. So this is probably the most exciting part of it for me, and I think a lot of the members on our committee. And the top part there, I don't expect you to be able to see this, I know it's quite small, but the top part there is general principles and risk factors that I've already gone over in the previous recommendations. So I'll just sort of zoom in on the pictures here. This is a nice one-page document where basically it says, if the bum looks like this is what you should do. So if you have intact skin, you're looking at prevention, you're going to pick a low to moderate percent zinc, maybe a petrolatum or a dimethicone, and then what to do with that. Again, if you have erythema on the skin, if you have broken skin, you're adding a stoma powder or maybe thinking about a cyanoacrylate at this point. And then if you have a yeast infection or any type of infection with that, you're going to treat the infection as well as the dermatitis that's going along with that. So this is just a couple of case studies. Excuse my bum picture, I should have warned you right off the bat, but this is James. So James is 7 months old. He was born with anorectal malformation. He had a diverting colostomy at 1 day old. He had the PSART procedure, which is a pull-through surgery, if you've heard that before, post-sagittal anorectal pull-through at 5 months old. And his ostomy was closed 8 weeks after that. He presented to clinic with me for his 2-week follow-through after his ostomy closure, and his bum looked like this. And I wish I had taken an after picture, which I didn't. I apologize. And it's a little bit hard to see, but right around his anus was quite open. Risk factors that he had: naive skin. So his poor little bum had never seen poop because of his anorectal malformation. He had a fistula, and it was actually into his bladder. And then he had an ostomy, so he had never pooped out of his bum. He had an anorectal surgery, so the cleansers, the tension, the changes to gut flora from the surgery are all risk factors. Stoma closure, same thing. And just to add insult to injury for this poor guy, he had oral thrush. And I think most of us know how thrush can travel through the gut. So it had traveled through to his bum as well. When he came in, the parents were using a low percent zinc barrier. They had tried 5 different types of barriers that they had received from baby showers and gifts. So they had tried everything that family had recommended. They were also smearing barrier into the diaper, so on the diaper surface. I think the idea to that was so it wouldn't wipe off the bum, it would be on the diaper, but it effectively took away any absorbency of the diaper to take the poop away from the bum. They were cleansing to bare skin. They were working really hard to get everything off the bum every time. And they were leaving the diaper off as much as they could, which is great. So we just tweaked their program a little bit. We added ostomy powder to those open areas. My great colleague Bridget that I work with always uses the analogy. It's like breading a chicken breast. You can't put an egg wash on a wet chicken breast. You have to flour it first so the egg wash will stick. Same idea. Wet cream doesn't stick to wet tissue that's denuded. So putting the stoma powder lets the cream stick to the skin. We switched to a higher percent zinc, so greater than 20%. Applied a very, very thick. My analogy is always cream cheese icing on a carrot cake. You don't want that thin, you want it really, really thick. And then cleaning off only what's soiled. You don't need to clean down to bare skin every time. Just clean off what's soiled. And then once a day or once every 2 days, have a nice soak in the tub to get the rest of it off with a good cleanser with those emollients to break it down. Keep leaving that diaper off for periods of time. That's great. And then the prescriber for James also added an oral antifungal since he did have oral and topical thrush. And then the second case I have for you is Namid. I wanted to choose, when I was choosing cases for you, I wanted to highlight that it's not just babies. So this is Namid. Namid was 13 years old. She had terminal cancer. And at the point when I met her, she was just not doing comfort care. She was at end of life, but she did have palliative chemotherapy going on. She was incontinent of both stool and urine, not ambulatory at all. She had a lot of pain when she moved. And she was also in extreme pain every time her incontinence pad was changed. And it was so bad that she actually required a hydromorphone bolus before she had an incontinence pad change. So this was what I found at Namid's bedside when I walked in. They had tried everything to try to get her comfortable, literally everything. I don't think there was anything that they missed on this this table of goodness. Her risk factors were chemotherapy. She had organ failure. She was at end of life. So her ability to heal was actually quite low to begin with. We were really interested in comfort and not necessarily healing. Pain. And I don't know that everybody knows that pain can actually cause inhibition of healing. So when you have extreme pain, your body goes into that stress response and your blood vessels actually vasoconstrict, and you don't get the appropriate cascade of healing factors to heal your skin. So when you're having pain, it is nice to treat for pain and not have everybody traumatized, but it also is an inhibitor to healing as well. She was non-ambulating, so she had pressure there as well. Her stool was very liquidy, and the treatment was obviously very inconsistent. So when I met her, the nurses told me they had tried everything. They were cleansing to bare skin every time to try to get all the poop off. They were using hospital face cloths, and I don't know about your guys' hospitals, but ours are equivalent to sandpaper. That's very rough. And they were considering a fecal collection device, which is actually what I was consulted for when I came to see Namid. But when I saw her and talked to the mom, kind of discussed the concerns, we decided to try an application of cyanoacrylate. Chose this over a barrier cream because she was having a lot of pain with any touch or manipulation. So we thought, one application a day, and then that barrier's there, and we don't have to do it again. We just have to use a gentle wipe to cleanse when she does stool. And I have pictures for you here. So the top one here, you can see day 3. So this was after 3 applications. We did daily applications for the first 3 days. You can see it's all healed, epithelialized, except right around her anus. And at this point, she no longer required hydromorph boluses for changes. By day 5, it was completely epithelialized. And by day 11, you can barely tell that she had a rash at all. And she actually died, I think, 3 or 4 days after this, with a healed bum, which is incredible. And the mom was just so happy she did not pass with pain from being changed like that. It was incredible. That's the end of my chat. I'm going to pass things over. Let's stop sharing here. And I'm going to pass things over to Jonathan because I am really looking forward to hearing about the Pediatric Association.
All right. Thank you, Emily. That was amazing. And having worked in acute medical, I've seen some of those bedsides. So I got so much from your presentation. And I'm not going to be able to, so my role here isn't to add into the the bum expertise that we have already witnessed. My role is to talk a little bit about the Canadian Association of Pediatric Nurses and about some of the advocacy, education, and the things being done for the pediatric health in Canada, and some places that some of you might be able to help us out with. And NSWOC and CAPN have just started to work together, so we're hoping for some of the next projects that might be down the line that we might work together on many new and exciting things to come. So let me share my screen and give you guys a little rundown on CAPN. So the Canadian Association of Pediatric Nurses. So we're all about connection, compassion, and commitment, leading pediatric nursing excellence. So I know there's probably many people out there who have not heard about CAPN, and for good reason, because CAPN is relatively new to the health landscape, kind of. So CAPN originally started in the 80s, but then it kind of went into what you might call a coma and existed only in a filing cabinet for many years in some nurse's office that I believe probably at sick kids. And then in 2017, a bunch of pediatric nurses got together because they wanted to have a pediatric certification for Canada, and they wanted to work together to increase the excellence of pediatric health in this country, because right now, unfortunately, Canada does not have great pediatric health. We are, I think, something like 29 or 30 out of 32 developed countries in terms of pediatric health. So we have a lot to do and a lot of work to do to change that from coast to coast to coast. So let me continue here. And there we go. So our vision is what I had at the beginning that I've already read out. Our mission, which I've already kind of touched on a little bit, and I need to move my box so I can actually read my own slides, to protect and to promote the health and well-being of Canadian children locally and nationally by advancing the professional specialty of pediatric nursing through education, learning, and advocacy. So, first of all, I wanted to kind of put this up here so people had an idea of, a lot of people are kind of a little uncertain about what national associations, there's all kinds of them. So this is the basic setup here. So you have the Canadian Nursing Association, which advocates for all nurses across Canada, and also connects in with the International Council of Nurses. And so they're involved in a more wide scope. And then affiliated with the CNA is 22 specialty nursing associations. NSWOC is one of them, and CAPN is also one of them. And we're part of the Canadian Network of Nursing Specialties. It's as it sounds, it's a network. We meet monthly and The network is just getting going on a lot of different projects. I'm not going to get into some of that stuff. And then CAPN is focused in on general pediatrics. We do also have people focused on more intensive care on the PICUs and the NICUs, and you have some different focuses. So if you look on the CNA site for the specialty certifications, you'll see there is pediatric intensive care and there's generalized pediatrics. And yeah, so let me continue on. And you see some of our main objectives there, which I'll touch on a little bit here. These are our current strategic priorities that we're working on. Education, which is part of the one here, where we're both working on developing our own workshops, but connecting with many different other organizations to help promote, work with them, develop all these different things. So I'm not going to go over, I'm going to do this quickly so that you guys can get to questions to Emily. And of course, if you have questions for me as well. One new thing we have, so our first version of the pediatric nursing standards came out, I think either end of 2017 or early 2018. Just a couple months ago, we came out with newly updated pediatric nursing standards. So please head to our website at www.pednurse.ca and grab a copy of that if you don't have that for your organization or your school or wherever you are tuning in from. And yeah, so currently for anybody who might be looking at pediatric nursing specialty certification, the current exam is based on the old standards right now, because this one just came out and then it's going to be a process before this one is integrated into the exam process. Yeah, and there is a webinar that's recorded on our website if you want a rundown of the standards. They're quite easily readable, I find, the standards. Oftentimes, I'll sometimes read through some of these types of documents and I have to focus myself, and I found this one really read well. Anyways. So policy and political action. This has been ramping up a lot in the last year. I have a bunch of different things up there. On the top there is one that I'm actually going to with our president, Rebecca Earle, next week. And we're going to a summit for child health in Ottawa, held by Children's Healthcare Canada. And we're going to have, there'll be children's health leaders from across Canada there, parliamentary members and different things like that. So we're very excited about that. We've also worked on a couple of different joint statements, a lot of them mostly with Children's Healthcare Canada and the Canadian Pediatric Society. I think one of the more recent ones was in the spring when we put together a joint response on the 2023 federal budget that was titled No Sense of Urgency for Canada's Kids. And as you can see, there's also a call to action that we've done with them, and we're continuing to work on these collaborations. You can see one of the meetings there that was one of those kind of federal meetings on children's health, and yeah, and working with a getting excited about working together and making sure that the different associations are not as siloed, because when we de-silo ourselves from acting alone, we gain power when we can work together. If I can come out with a statement from 5 different organizations, suddenly that is going to be a voice that is heard. it is much more powerful when a document comes to a parliamentary member's table and it has 5, 6 different national organizations all saying this needs to be done. That has a lot more weight to it than a single organization could ever do alone, no matter how good their research, no matter how good the document. Okay, continuing on is education. This is one of the ways we're working on education, is partnering with other organizations. We're planning on doing a workshop for nursing students who are interested in going into pediatrics, looking at some of the ways that you prepare for interviewing into pediatric positions and preparing in different ways. So stay tuned for that. We don't have a date yet set for that, but I believe some, yeah, hopefully we're hoping for that to be hopefully either in December or January. We will see. We are going to be forming an education committee. So if any of you would like to be involved, but don't want to be a part of a board of directors or take on a position, we would love for you to be a part of our education committee. And that is flexible, because you might be more involved with one piece of it. You might just be involved in editing something or putting something together. So it's a lot more flexible. And you might be involved in one specific project that you're really passionate about, that you want to work together with us for. And we would love to help with that, especially if it's something that you might be doing in your small area that you want spread to a national audience. And that's something that we would love to help you to work towards. And I've already mentioned some of the other things there. We also have a bunch of social media presence that we're working on, and we would love to get contributions from any of you that are interested in contributing towards some of this kind of stuff, because we do things like Future Fridays. If you have an amazing pediatric team that you want to highlight some of their creativity and awesomeness and want to send a submission for us to feature on our social media, or you have a tidbit of knowledge about pediatric health that you think people should know, we would love to help spread that knowledge. And yeah, any things like that you want to help share. And it might be something that you've made for your organization and just want to share and say, hey, thought you might want to share this. I made this for my hospital. Awesome. Yeah. So connect up with us, and you can scan that to connect up. That, if I'm remembering the QR code, that should get you into a bunch of things. I'm realizing right now that I did not write our main email address on here, but you can find that on our website. As I said, www.pednurse.ca. That's PAED. Yeah. So continuing on, some of the things we're working on. As I mentioned, committees are one of the things. There's 2 committees that we're starting with. One is the education committee, and the other one is our membership and marketing committee. Education committee is pretty self-evident. The membership and marketing is all about helping to put together resources for nurses across Canada, really, because it's all about working for the members, the pediatric nurses. So whether it's finding partners to help provide services for nurses, or benefits, or helping to make official partnerships, all kinds of things like that. That is what that is involved in. Yeah, we're continuing to promote the pediatric specialty certification. For me, when I got certified, there's a bunch of reasons to me to get certified, whether it's in pediatrics or whatever specialty you want to get certified in. One is just employment-wise. If you have that on your resume, that makes you a much stronger candidate because it proves your knowledge. You can say, I've worked for 5 years in a pediatric organization, but having the certification says, I'm also at a certain level of expertise and knowledge. I also, a big part of it for me is sometimes just for myself when I'm having a hard shift and I can look down and say, no, I'm certified. I can do this. You're a pediatric specialist. You got this. And many other things. I don't want to take too much time here, but please connect up with us. We would love to, the more people connected with CAPN, the more strength it has and the more we can do and the more we can progress and improve the pediatric health for everybody across Canada. So yeah, please connect with us, stay connected on whatever, yeah. And that is my presentation.
Fantastic. I'm been trying to turn on my video. I'm not sure what's going on here. I was saying to Emily and Jonathan before this that I've done about 100 webinars now, and for some reason today it decided to be a technical glitch. But hopefully you can hear me okay, and I would love to ask a couple questions if you two are up for it. Awesome.
Yes, we can hear you perfectly.
Fantastic. Okay, so we do have a couple questions. So the first one is coming from Nadine here, who's asking about the recommendation for air. I'm trying to see if I can simplify this question a little bit. I think the question is air exposure alone sufficient to prevent moisture-related skin problems, given that some nurses in their institution have been using oxygen from the wall for drying despite their advice?
And I don't think it's wrong to use oxygen from the wall if you have it. Just know that it's not a treatment. You're basically using the oxygen on the wall as a blow dryer on cold versus oxygen treatment. I mean, the oxygen won't, it might help a little bit. It's not enough and not pressurized enough to be a true treatment of oxygen. But just letting it dry alone is enough. I hope that answers the question.
I think that's perfect. Well, thank you for touching on that. And then another follow-up question here is about how can you put on an antifungal cream without taking off all of the protective barrier that you might have to do a few times today or 3 to 4 times a day? Would it be a good idea to ask the pharmacy to mix the antifungal cream with powder? Have you run into this before? Is this something you might be able to touch on?
Yeah, if your pharmacy will premix it, that's great. Ours doesn't. But I find that the cream wears off anyway. By the time you get to the next diaper change, there tends not to be enough there that's going to prevent it from actually reaching the skin. So using the antifungal when you're supposed to, so usually 3 times a day on the bare skin, just don't scrub to get to bare skin. But the skin is usually exposed enough that you put the stoma powder on, put that antifungal on top of it, or if you're using an antifungal powder, put that instead of stoma powder, and then your barrier cream on top. I haven't really had a lot of cases where I've had to move the barrier cream to get the antifungal on. It's usually worn off enough by that point.
Perfect. Well, thank you for touching on that. I'm going to switch gears a little bit and talk more broadly about the best practice recommendations document itself a little bit here. So one of these questions that came up here was what motivated you and John and the rest of the team and the community of practice to start developing these? I know, John, you mentioned, Canada's lower ranking amongst developed countries as well for well-being for children and youth. Was that one of the main reasons? Was it some things that you were, as a committee, noticing yourselves in your own practice? What kind of brought you to deciding to work on this best practice recommendation document?
We really, like I said when I was talking there, we rapid fired all of our ideas of everyone's passions, what we need to work on. And that was the one that sort of rung true across the board to everybody, that we all deal with this. We all have a algorithm we use in our hospital, but nothing is evidence-based because there's no evidence, or there's not a lot of evidence for pediatrics out there. So I think it was really just, we honed in on that was the the first project we wanted to tackle, because that was sort of the most broad and the biggest issue across the board for our committee.
And I think, I know I speak for myself, and I know probably most pediatric nurses out there have had many cases of feeling like they're stumbling in the dark, trying to figure out how to help this baby, this child, heal amongst everything going on everywhere. That's one thing that I've seen many times that gets it ends up lower on the list than it should be. And I've seen it many times where some of these infections, like, because there's these 5 other big things happening, it doesn't get talked about until it's a really big issue. So to me, I think these are amazing and extremely valuable for helping nurses to help their patients, because sometimes it's hard to get that onto the top of the priority list, especially when it's hard to find the information.
Absolutely. And I know in the best practice recommendations, they talk about the need to standardize some of this and how helpful that is too, to be talking with the same terms too. I'm going to kind of go back and forth here from to some more clinical questions and back over to the document there. We did get one question that came in from someone who was asking, do you use the same type of creams? Like you're going to have to, excuse my ignorance here, dimethicone, I think is how it's pronounced, dimethicone and zinc in the same strength for both adults and children, or using a different type?
Oh no, I mean, they're all different strengths depending on the brand, the manufacturer, the type that they have within their line. But it would be the same. It would be the same type of concentrations for adults and children. Yes.
Perfect. All right. Well, going back over to the best practice recommendations documents here. One of the recommendations, of course, number 5, they were talking about a bit more the interprofessional collaboration and involving the NSWOC or a wound care specialist later. Did you want to just kind of talk a little bit more broadly, maybe, about how big of a difference that makes when we start to involve both the NSWOC and really making sure that interprofessional collaboration is at the forefront of pediatric care?
I just think it's so important. I know, speaking from my own practice, just knowing that we exist within the hospital and we're, nurses, floor nurses, staff nurses are not alone, and that when they're feeling stuck or like they can't get anywhere, knowing that you have someone with a little bit more advanced wound care knowledge to come and back you up and help you look at the situation, kind of go back to that first recommendation and look at the holistic picture of this patient and what could be causing the issues. Just knowing that you have somebody there to come and help you with the wound care aspect, I think is huge. And I mean, I'm very proud to be an NSWOC in our hospital and be able to provide that support. And then the education, especially as we have this document that we can kind of present, and that education will spread through the staff, and they will start to kind of get a little bit more independence with, this is our algorithm that we're going to use. Personally, I've taken it in my hospital now and put the products that we have in-house kind of next to those categories of products that we have generally listed, so that they have that available to them.
Absolutely. And while you're mentioning that as well, just a quick reminder to everybody on the line that you can access all this information on our NSWOC.ca website. It's you can see it in the chat there. It's /BPR. We have all of our best practice recommendations documents and quick reference guides and any other accompanying material. All that is for all of our best practice recommendations. It is all listed there. So definitely take a look at that. And as you mentioned at the beginning, these were launched back in July, so it's still a fairly new document. So if you haven't seen them before, if your colleagues haven't seen it yet, make sure you do help us out there and circulate those and share them. We'll definitely be doing a follow-up email with it as well, so stay tuned for that. Another quick question here, and it's talking about recommendation 8 when we're talking about collaborating with all individuals involved in the care of the infant or child. You mentioned this at the beginning of your presentation there, Emily. I'm sure you probably aren't the only nurse who has gone through this before, but have you run into difficulty before where it has been difficult to be collaborating or working with other people around the infant or child? Are you able to share any sort of stories like that others might be able to relate to?
I feel like that's always an issue.
Yeah.
We constantly, I mean, I'm thinking of a particular baby that we just not that long ago dealt with, and we came and made some recommendations. We wrote them, we put it all over the care plan, but it wasn't followed. And then plastic surgery was consulted, dermatology was consulted, but because they were siloed, nobody talked to each other. We didn't know plastics, who we worked very closely together with, was consulted, so we didn't know the recommendations that plastics had made. And then dermatology made recommendations that were different than plastics, and I mean, we were all kind of saying the same thing, but with little differences. And then the staff and the family don't know what to follow and who to listen to. So, and I don't think it's a who's got the final say. I think we really just need to make sure that we're collaborating and talking together so that the family and the staff that are trying to look after the patient aren't getting 3 different avenues and trying to decide which one to follow, or following all 3 and not being consistent and not having the outcome that they're looking for.
Thank you. I'm going to go over to recommendation 4 now. A quick question about this one's about the 3 to 5 days for the recommended duration of skincare regimen. The question essentially is asking, could you just explain a little bit more in detail about what the rationale is behind that duration and the circumstances under which it may be or may need to be reassessed before the recommended time?
Sure. 3 to 5 days is approximately the amount of time it takes for a superficial partial thickness wound. So that would be what diaper dermatitis is. The top layer of skin is damaged and possibly sloughed. If you're seeing that kind of moist breakdown, that's approximately the amount of time it takes to epithelialize if it is treated and covered and allowed to do so. So putting on a barrier cream for 12 hours and then expecting it to be healed isn't necessarily a realistic expectation. So we need to allow the treatment time to actually treat before changing to something else, where you kind of rewind the clock and start all over again. I forget the second part of that question.
No, yeah, just the circumstances under which it might need to be reassessed before the recommended time.
Absolutely. So if it's getting worse, if the rash is breaking down more, if you're seeing more bleeding or more pain or discharge, those would be circumstances where you would absolutely want to stop what you're doing and change.
Perfect. Thank you. And I'm just going to reiterate what Caitlin is saying in the chat there, that they've done something similar at their hospital to create an algorithm for PIAD with assistance from other NSWOCs, of course, as well, and made sure that the product was stocked and have not gotten a call from NICU since they implemented, and the staff love the tool. So there you go. Get it. Some perfect feedback right there.
That's exactly what we're hoping for.
Exactly. Jonathan, I might turn it over to you for a second there. I know you were sharing quite a few of the QR codes and everything there. Would you be able to pop that back up on screen again, just in case people weren't able to scan it the first time?
Yeah, I'll pop that up. I'll also put the website in the chat here, so if people want to go directly to the website, they can as well.
Fantastic. And did you want to maybe talk a little bit? I know you introduced us quite a bit there to CAPN. Is there anything else you wanted to, well, we still got everybody on the line here. Is there anything else you wanted to let everybody know about the association before we kind of head off? And any sort of big promotions, not promotions, but anything else you want to say about CAPN before we wrap up the webinar today?
Just that, like, as I had mentioned, we really are the people, the group. Talking is, there we go. We are absolutely passionate about making connections. And as I mentioned, one of the big things is to de-silo, as Emily was mentioning about de-siloing, about the different interprofessional within an organization. It's the same with de-siloing our major organizations. Because say, for example, if Emily is creating a tool for orienting new staff in her organization, well, how amazing would it be if she can make it and used in her organization, and we were all making use of it across Canada? Well, hey, then you don't have 15 people all making the same thing. You could have 3 people making one that's much better, that is used not just in the pediatric centers, but the person in a remote nursing station in northern Manitoba could make use of that. And if we get that stronger education, and I could go on about this kind of topic forever, because when you spread out that education and that knowledge, and you're talking with each other, then you don't have the high numbers of pediatric patients going to the big centers, because now there's more education available and more expertise available to the smaller centers. They don't feel as panicked and need to send somebody out right away. Like, there's all kinds of benefits to talking with each other. And then one major goal of Children's Healthcare Canada and CAPN and the Pediatric Society is try to get a comprehensive plan for pediatric health nationally, which we do not have at all right now. And to also advocate for a chair of pediatric health for Canada, whose sole job it is to advocate for pediatric health on a federal level. So those are 2 of the really huge things we're passionate about. And I'm sure there'll be documents and things trying to fight for that coming out for people to help spread around. Yeah.
Absolutely. Well, thank you for talking about it. And really, that I think that's been a key. You're talking about removing the silos or attacking the silos as much as we can, or being able to work collaboratively together. That's been a key theme across all of our summits that we've been having the last little while. Our wound ostomy content summits that we started out in Nova Scotia, and we've since had a New Brunswick, Alberta, and we're going to be going into Ontario hopefully very soon too. But that's been a key theme that keeps popping up. So we're glad to see that CAPN is back up and running and is growing so much, and we really believe in your mission as well. So thank you so much for talking about that today, and of course for your contributions to the PIAD best practice recommendations. Emily, also in closing here, we had a couple questions earlier about how someone can get involved with the community of practice. Did you want to maybe just speak for a second about again about the community of practice, who we kind of have involved there, and how someone can maybe reach out to us?
Absolutely. It's open to anyone who's interested in pediatrics. So one from NSWOC, SWAN, nurses who are not involved in our association yet. You can absolutely, the email, I think Troy put it in the chat there, send an email and inquire, ask how we can get involved. We definitely have more projects coming up. We're looking forward to expanding and helping in pediatrics across the country with all of those listed issues that we already came up with, and many more likely. So yes, if you're interested, send an email and see if it's something that you want to be involved in.
Thank you so much. Okay, well, on behalf of us at National Office here of Nurses Specialized in Wound, Ostomy, and Continence Canada, we want to thank both of you for your hard work, and again, the rest of the team. I know it was a big team that worked with you to put together the document. So we really look forward to people sharing this, accessing this, and of course benefiting from it for the better care of our younger patients here. So thank you so much to both of you, and we hope everybody on the chat tonight or everybody on the webinar has a good rest of the evening.
Thank you.
Thank you so much, and thank you so much for NSWOC for inviting CAPN to be a part of this, and we look forward to future collaborations.
Absolutely.